This podcast, I had the pleasure of talking to Dr. Bilal Chughtai, who is an associate professor in urology at Weill Cornell Medicine here in New York. Dr. Chughtai treats the body as a cohesive system with a focus on urological care. So, one of the reasons how we connected some years ago when he asked me to be one of the editors of the book Healing in Urology is because, as a urologist conventionally trained, he is actually holistic in his thinking. He believes it is just as important to address the immediate symptoms as it is to examine the underlying causes of the urological complaint. Dr. Chughtai is an active researcher and a primary and co-investigator in numerous studies. He publishes a lot of papers. Currently, he has over 160 peer-reviewed articles that he has authored. He is a specialist in voiding dysfunction, neurourology, and female urology. On this podcast, we talk about overactive bladder in men. He breaks it down and lets us know exactly what overactive bladder is, what are the causes, and why in men most physicians think that when they present with a urinary problems that is automatically prostate related. And we talk about that. I think that's one of the wrong things that's done in the urology field. He also talks about the different treatments. He talks about the different alternative treatments and all sorts of treatments for overactive bladder that include things like botulinum or Botox. That's right, Botox for overactive bladder. So enjoy this podcast with Dr. Bilal Chughtai. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my intention to help you with your prostate health and how to live better with age. Today, we have the great pleasure of having Dr. Bilal Chughtai from Cornell. And you already know much about him from the intro. So, Bilal, welcome to the show.
Well, thank you for having me.
My pleasure. Part of the intro, I spoke a little bit about the book that we co-edited, thanks to you, because I had no intentions of editing a healing in urology book. But what I didn't say is the following. You know, I don't know. You've written many things, and I don't know how you feel with your writings. Sometimes I put my writings aside, and I don't want to look at it after a while. It's almost like I need a break from it because you spend so much time and energy and in it that you need a break from it. But every now and then I pick up one of the books that I'm involved in, and I'm like, wow, this is actually a really good book. So it used to be after we published Healing in Urology that people used to say, hey, is there a good like complementary medicine urology? And I'm like, man, I don't know. Meanwhile, it's right there in my face. Until then I opened up one of our books, or the book that we co-edited, and I'm like, and I looked at it like fresh eyes. Wow, this book is actually really, really good. So I want to start by saying that book, Healing in Urology, we got great authors who contributed with chapters, science-based, kept the scientific integrity of the book, and really useful for. The other thing that I found that was really good is it's almost, it's like right in the middle where practitioners can pick it up, learn from it, but even lay people, because it's not overly complex, though there are references and so that was a good call. And I am still, and it's been a while now since that book has been out, and I'm still very fortunate and privileged to have participated in it. So hey, this is a thank you that I might have told you 5-6 years ago.
Gio, I would completely agree. That book was it's really interesting because like I'll have patients come in and they'll have copies of the book, and like I'll go through some of the pages. I'm like, wow. I was like, I remember that, and I was like, that's a useful fact for me to know, and I'll bring it up to other patients later that day. But it's remarkable because like I think one of the focuses that we had was to keep it very evidence based, and I think it kept us really grounded, and it kept the book very scientifically sound, which was great.
Yeah, and practical. Sometimes things are so evidence based that it's not practical. Sometimes
Yeah.
it is too practical. It's like, where's the science? Why are you telling me to do this? And this particular book does both. So yeah, no, it's remarkable. So thank you once again for allowing me to be part of that book. Bilal, a little bit of background. You went to medical school. You went to urology. You did a residency. Then you said, yeah, I like this, urinary function component of it. I like to do less, I don't know, kidney stones and probably not so much ED and not so much prostate cancer. I want to get into, LUTs and urinary dysfunction. Why? Why did you choose that path?
Yeah, so I've always gravitated towards conditions that affect quality of life, and I found this area to have lots of innovation, but the science behind it, there was a lot of like areas of like exploration, and also like patients are tremendously motivated in this space as well.
Hmm.
So it was an exciting area where I saw opportunity for innovation, research, and the ability to sort of really make the field better over time. So
Hmm.
I took the opportunity and it's been great.
And it's one of the areas in urology because the urologists are known as the male gynecologists, but no, in particularly your area, you see many females.
About half my practice is female.
Right. Right.
Yeah.
Yeah. And look, I'm glad. I've learned throughout the. So I've been in urology for over 20 years now, which is just remarkable. And I've learned that in most places around the world, certainly even in the country, not everyone has the luxury of becoming a subspecialist within urology. They are everyone is a surgeon, so it could be that they do, prostatectomies, but they're also treating the urinary incontinence that comes along with that. They don't send them out to a specialist. And here we are, or at least in New York, I think, or in big cities throughout the country, we have the luxury of having subspecialists at NYU, Weill Cornell, Columbia. It's remarkable.
You're right, and I think that sometimes gives us the ability to really hone in on that condition, and it's great. Like a patient will walk in, and I mean, it's pretty rare for someone to bring up something that I haven't come across, whether it's a novel like device off Amazon or a novel alternative therapy or a therapy that's like not even FDA approved yet.
Mm.
So it's great. So it allows me to really specialize in it. But I think we're also all built different. I think some of us, like I think you and I, like particularly enjoy an area of urology. I think
Yeah.
that's why that Healing in Urology book was like, it was fun to write. I learned tremendous amounts of information as we wrote it. And it allows me to be like a real expert in that field.
Mhm.
And I think some of us are built to be, we like the variety. But I'm more of I love knowing a lot about one area. And I
Yeah.
think that's why like this, I've really honed in on it.
Yeah. Yeah. Overactive bladder, Bilal. Overactive bladder, right? So before we go into that, when I learned or the diseases and pathologies during school, I always went back to learn. All right, how does this particular system supposed to work, and when is there the dysfunction, right? So how we're gonna segue in a minute to overactive bladder, but in bladder function 101, how does that work? How does a normal bladder work?
Great question, Gio. So a normal bladder has two functions. One is storage and one is emptying. So the idea is that the bladder is supposed to be able to hold lots of urine, call it cup and a half, 2 cups, and when it's socially appropriate and the person is ready, they're able to completely empty their bladder and then restart that cycle again. And that's really how normal bladder function is supposed to work. Now, obviously, we're really way oversimplifying. Like we're
Sure.
not talking about how the brain function comes in, pontine maturation center, how the spinal cord, but ultimately that's the underlying, that's the function that we're trying to correct or what's not correct during overactive bladder.
So here's what we're going to do. We're going to go a little bit deeper, not too deep. This is not a medical school course, but we're going to go a little deeper because I think as we discuss overactive bladder, a little bit more of how it works will be meaningful later on in this conversation. So, how you said about 2 cups of water of fluid, it's normal, and obviously this is a rough estimate in terms of what your body, what most bladders can, normal bladders can hold. In terms of how many, so when they do, let's say, and a lot of the listeners have an idea because they've listened to the podcast, of what to do, a post void residual test, right? So I have an idea. What should that number be before you say, "Well, it's a problem"? And I know that, and I found that everybody has a different response. How many cc's can they
Yeah.
hold before you say, "Hey, that if there's more than X amount, and then it's a problem"?
Yeah. So let's clarify. So a post-void residual is the amount of leftover in the bladder after you're done urinating. That's a good question. What is completely normal? Because what if you look at the literature, post-void residual hasn't really correlated with many outcomes. But we do know that as the bladder function deteriorates, post-void residuals go up, and those are patients who may be at risk for urinary retention. But typical post-void residual should be around 10% of capacity. When it comes to overall bladder capacity, again, what is normal is, let's call it cup and a half, 2 cups, but there can be patients who have a liter in their bladder and they do perfectly fine for long periods of time. So unfortunately, as you and I both know, when it comes to the world of medicine, we've studied abnormal quite well, right? And we have lots of information on abnormal. We don't have great information on normals. And even when you get into the definition of overactive bladder, it's defined by greater than, 8 voids in a 24-hour period. But wait a second. How many glasses of water are you taking in? How much is
Right,
the appropriate amount of fluid? How hydrated are you? So there's a lot of things we don't always have great answers for.
right. Um, so okay, so you give us a really nice overview of the bladder, how it works. Now, what causes the feeling of having to urinate? It's when the bladder stretches. You correct me wherever I'm wrong here. The bladder starts stretching. So it's signal to the area of the brain. Is the brain stem?
Yeah, Pontine Maturation Center.
Pontine micturition center, and there's a reverse motor neuron that comes back as, all right, I need to, and so the signals goes to the mid center of the brain somewhere. We won't get into the weeds, and so I don't butcher names here. Tells the brain, hey, I need to pee. Then whenever there's the right time, the right opportunity for you to go where it's socially acceptable, then you go and you urinate. So the nerve function plays a role here, and I think it's is that correct? Is that a correct summary neurologically?
So high level geo. Like, so essentially, what it is that the bladder always wants to urinate and it's always sending a signal up to the brain saying, you know what, I could pee, right? But the brain sends a signal back down being like, you're really not that full, right? So what'll happen is that these signals should be on a very gradual level, right?
Mm.
So eventually you get a very gradual urgency. And at one point you kind of go, oh, wow, I really have to go. Then once you have that sort of sensation, you've got an adequate amount of time to make it to the bathroom, right? And at that point, you could empty the bladder. But there's also many factors that get into it. Like there's the frontal cortex that plays a role. There's lots of things that play a role to sort of like make those signals not as reliable. And that can lead to the idea of urgency, that sudden urge to urinate, or frequency, urinating very frequently.
Hmm. What are so then around the bladder, and in men between the bladder and the prostate, there's these receptors that also helps us urinate under normal circumstances, right? Discuss that a
Yeah.
little bit, because then it's going to go into treatments and things, and dysfunction and treatments as we continue to the
Yeah.
conversation.
Yeah, so the two main receptors that are important for like our conversation is that there's the M3 or the muscarinic 3 receptor, and that's what makes the bladder go, right? It makes it squeeze, right? So by paralyzing the muscarinic receptor, the bladder holds more urine, right? The other receptor is the beta 3 agonist, which allows the bladder to do a passive stretch and hold more urine. So the muscarinic 3 receptor prevents the contraction. Beta 3 allows the bladder to passively relax more. So those are the two receptors that probably play a pretty big role in normal bladder function.
And that's stimulated by the central nervous system. It's not the same nervous system we were talking about before. It's a different nervous system, more of the central nervous system that dictates when any one of these receptors are stimulated.
Yeah.
Right. Great. So, right. So if I have to go, and I have this feeling that, you know what, I could hold it for maybe 30 minutes. Who knows? No problem, until it gets to the point where the bladder really stretches a lot. It's like, okay, now I need to really go, and the signals are sent to the brain, and there's another signal that comes back to the bladder, and it's like, okay, whenever I'm able to go in a situation, I'll go. And that's more or less how it works. So in a situation where there is overactive bladder, and the name sort of says it's overactive, but what's really happening there?
Great question there. So when it comes to overactive bladder, we don't have a known cause per se. So it's not like we know that it's going to be related to nerves, muscle. We think it's multifactorial that play a role. We do know that it's more common in women than men. And we do know it becomes more common as you get older. But we don't have an underlying cause of overactive bladder.
So what's happening? So the way I explain it to patients, for example, is, look, you can hold 2 cups of water, no problem. Or you should be able to hold 2 cups of water, no problem. But your bladder, once it has a half a cup of water, let's just say, it's acting like if you have 2 cups of water. So it's very sensitive, and is sending a lot of signals at a very low volume of fluid in your bladder, as if you need to go now. Is that, at least in part, what's happening?
Yeah.
Overstimulation, or lack of stimulation, or overstimulation of those muscarinic receptors, all of the above, sometimes one, sometimes the other. What's happening there?
Yeah, so that's a great question, Gio. So I think that's a great explanation. And I give very similar explanations as well. But the question is like, wait, is it that the bladder muscarinic receptors are firing too much? Is it that the brain's not suppressing that urge enough? It's a good question. So we don't know exactly where in the pathway it's sort of getting the dysfunction. But effectively, that is what's happening, which is that you're getting signals before you're supposed to get them, or you're getting signals not on a regular level. So in other words, you're getting no signal, no signal, no signal. Then all of a sudden you get this, whoa, 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 I'm overly full. And you get
Mm,
that sudden urge to go. So there's something up with the signal that leads to either that frequency or urgency.
mm, mm. Bilal, earlier you said this. You said, overactive bladder is more common among women than men. How do
Yeah.
we
So
know
we do see,
that? How do we know that? Right?
so
Because
that is,
what? Because you gotta nod here, because you see men, and often, like, I had a man yesterday, 82 years old, and to me, and again, I'm not a specialist like you, but I've been doing this long enough. You know, 82 years old with what seemed to me like overactive bladder, but of course, 82-year-old man, it has to be the prostate. So he gets prostate medication, not, overactive bladder medication. And I'm thinking, there's no signal here. His PVR is fine. There's no signal here that it is his bladder. So I think there are way too many men diagnosed with prostate problems, and it's probably overactive bladder, not a prostate problem. What are your thoughts on that?
I think you're 100% right. I think what ends up happening is that we blame the organ that we own, right? So what happens is
I like that.
women
That's
don't have
great.
prostates. We don't blame the prostate.
We
A
blame the
man
organ
comes
that
in with
we
a
own.
prostate. We go, hey, it's a prostate problem. Must be a prostate problem. And I would say probably two-thirds to three-quarters of the time, it probably is a prostate problem, right? But there's a fair number of men, like, especially when they come in with predominantly irritative symptoms, these are the patients that when we move on to from medical therapy to some type of procedural therapy, I always get urodynamics because I want to confirm, is there truly blockage or is it truly a bladder problem? Because you're right, if you end up doing the wrong sort of therapy for what they have, they don't get any improvement. But there are a fair number of men out there with overactive bladder that have been diagnosed with enlarged prostate, and they get very little improvement. And a lot of times they think, "Oh man, I'm the guy where nothing works."
Right. Been on finasteride, been on tamsulosin, or both for a long time. Some relief, not a whole lot. and it's overactive. So actually, you answered the question. You answered my next question, because my next question was, how do you differentiate? And what you said was, you differentiate the only way, probably, unless you could do it just by in an intake. The only way is through a urodynamic, right? What's a urodynamic?
Yeah, so Gio, we'll go back one step, and I'm trying to be in good synergy with you. So I'm trying to predict your next question. Um, but I would say that so the way that's actually really helpful is actually bladder diaries. So bladder diaries are incredibly helpful as well. So they help you figure out sort of the voided volumes. So in other words, when you see someone having like you know greater than 8 voided volumes, each one being like less than 150, you're like, whoa, 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 this is very concerning for overactive bladder. You look at that Euroflow. If someone's got a Qmax, so in other words, their flow rate is faster than 15 cc's per second, that's also very telling for overactive bladder. But the gold standard, or the best way to tell, is going to be urodynamics, which is a test that involves placing a catheter inside the penis, a catheter inside the rectum. You fill up the bladder, you measure pressures of the bladder, and it helps you determine if there's obstruction or no obstruction. But I would say that the real key here is, and I think you're awesome at it because I've seen a lot of your patients as well, is like you do a good history and physical. When you see that patient coming in with urgency, frequency, good flow, never complains about weak stream, that really helps tell you what their underlying diagnosis is.
That's pretty much what I go by, and a Euroflow, which actually there are apps there for that you alerted me to some time ago. But that's, yeah, that's pretty much what I've seen. So it's still like, wow, why and I'm always, I am not the practitioner who complains or criticizes any other practitioner. I'm really thinking like, wow, what am I missing? Because to me, this 82-year-old that's not having a weak stream and not complaining of that, it sounds like overactive bladder. So what am I missing? Why is he on finasteride? Which is, I was talking to Mohit Kara from
Mhm.
Baylor, and he's like, "Yeah, I really don't like, 5 alpha reductase inhibitors on patients in terms of what it does hormonally. So I don't want my patients to be on these drugs unnecessarily, specifically. So um, it's
No,
good
I
to.
would I would agree with you. Yeah, I would agree with you 100%. I mean, what ends up happening is that a lot of times when you listen to the patient, they can give you a lot of hints of sort of what's happening. And I think what you're doing, and especially a lot of these medications, they are designed for the patient to be on them for the rest of their lives. So when you talk about finasteride, I mean, you're right, hormonal drug, and there's a lot of data talking about concerns with long-term exposure to those meds.
Yep. All right. So let's talk. And I am truly integrative, as you know. There are more. I find that some heart 100% medical doctors are way more natural than even I am, and they don't do anything, medical. And I'm like, no, some of these things work. You know, in the right person, in the right person, Tamsulosin is a fabulous drug, low side effect profile, and it works. It's like, my God, this works so well. And so, sure, my bias, first line therapy, let's look at natural lifestyle. For example, metabolic syndrome and OAB, a lot of correlation there, a lot of research saying, people with metabolic syndrome, which is a cluster of symptoms, right? Where it's, high LDL, bad cholesterol, big waist, people that just don't take care of themselves, a big waistline, they typically have more OAB. Constipation, our colleague, but really your colleague more than mine, Steve Kaplan and colleagues wrote a decent paper not that long ago on the association between the bowel and bladder connection, right? So things like constipation can induce overactive bladder or urinary frequency, for example. And there's a neural connection there. So there's a lot of these components. So natural to me
Yeah.
is, and lifestyle but some of these drugs work well, right? And some of them have low side effect profile. So you mentioned the two receptors. The first line of therapy is what in a person with overactive bladder?
It's what
Let
you
you
said.
answer.
So, so,
Yeah.
so the first thing is you ask about all those questions. You ask about what your diet intake is, intake of bladder irritants. You talk about reducing irritants. You can also include like reducing constipation, reducing waist circumference. So these are all things that you can start off with. Once they fail dietary and behavioral management, then you can go on to the use of medication.
Or they don't fail, but compliance is difficult. And I don't shame anyone when compliance is difficult. They're, you know, exercise, eat right, sleep well, blah, blah, blah. Life is life. And some people have very complicated lives.
Gio, you're 100% right. And that's so a lot of times what I try to do is visit number one, right? Let's rule out all the big bad things. Let's rule out things like bladder cancer. Let's rule out infection. Let's rule out all that stuff. Then I take a step back and I go, look, there's a multitude of ways that we can address this. I'll give you a list of things that you can do. And also keep in mind when it comes to bladder irritants, not all bladder irritants are the same for everybody. Some people will go, look, I get terrible urgency frequency with dark roast coffee, but light roast, not a problem. So
Hmm.
I'm like, great. So this is a small fix that you can do without getting rid of coffee altogether. So there's things we work on like that. Some patients are very inclined towards like, look, being realistic, I'm not going to be able to change my diet. So let's talk about moving on to medication or adjuncting with medication, or sometimes the use of alternative medicines.
Mm-hmm. We're gonna reverse engineer. We're gonna do a little like, okay, what are the meds, and here's why. So the reason why I asked you to mention those receptors is because a lot of those current drugs are antagonists to those receptors. So we have anticholinergic drugs or antimuscarinic
Hmm.
drugs. So they are they block the muscarinic receptor, and then we
Hmm.
have um, beta agonist drugs as well. So
Right.
in last year's AUA, and I don't think it was new news, but it was news that at least you always come out of the AUA. So the AUA is the American Urological Association meeting, and most people go, and you try to come away after a while with one or two takeaways that you can use clinically because sometimes you're giving those talks. So one of the things that I came away with there is like, wow, these anticholinergic drugs and the association with cognitive decline. And then I have a few systemic reviews. Can you talk on that? Because right, who are the ones taking these drugs? Typically elderly people, and so then that's not a great trade-off if you ask me.
Yeah, so what we're seeing a lot of is that when you look at anticholinergic drugs, these drugs can, cross the blood-brain barrier. And when we talk about the muscarinic 3 receptor, there's other muscarinic receptors that occur in the brain, in the mouth, in the gut, in the stomach. So you can end up with other side effects. And the problem is when they cross the blood-brain barrier, that can lead to, cognitive decline. And these drugs have been very much linked to it. And you're right. Unfortunately, as we get older, our cognition gets a little bit more delicate. You add on these drugs, and now you're adversely affecting cognition even more. So these drugs have gotten under a lot of scrutiny. Now, a lot of the data that we're seeing is for the non-specific drugs that are a little bit more easier to get, but they're also the ones that are uh, insurance tends to approve. The more specific drugs that are muscarinic antagonists, antimuscarinics, those drugs sometimes are harder to get approved through insurance. And beta 3 obviously are newer drugs that don't have that side effect at all, but they sometimes can be very challenging to get approved by insurance.
Interesting. We're going to go into beta 3 drugs in a second. The other thing with anticholinergics is a lot of them seem to cause constipation, and we already said, wait a minute, there is an association, correlation between constipation and overactive bladder, but we're causing at least part of the problem. So it's almost like the 5 alpha reductase inhibitors. Like, those are not my favorite drugs for overactive bladder at this point. They're not my favorite if I have to choose one. So are we on the same page a little bit here, more or less?
Yeah, absolutely. I mean, when you talk about antimuscarinics, you're right, and not only. what happens, like, so you've got this overactive bladder complex, right? So what's a natural reaction for patients to do? Drink less water. What does drinking less water do? Cause more constipation. What does causing constipation do? Cause more urgency frequency. So a lot of these things do exacerbate. Now you add on the anticholinergics where now you got dry mouth, so now you're drinking more water for the dry mouth. It's causing constipation. So you have to be very careful, and it's very important, I think, to educate the patient on the side effects and sort of mitigation strategies. So a lot of times I'll tell patients, like, look, we'll start an anticholinergic, but don't start drinking tons of water. I want you to think about a sugar-free candy. Or you're going to have constipation. You can drink some extra water, but let's try to get you into a good stool softener to help reduce reduce constipation risks. So you have to educate the patient about these side effects.
Right. With the beta 3 agonists, right? They're agonists, not antagonist.
Correct.
Yeah.
So they're beta 3 agonists, so they actually stimulate the receptor.
And I think we can mention at least the trade, the if not the trade name, the generic name, if you want. I think I know, I think I know the trade. They're doing such a good job marketing at our office. I only know the trade name. Merbetric is the one of the drugs.
Yeah, Mirabetrip or Mirabegron is a generic name.
Merbagron. Yeah. Are there? I don't know of another. Are there
There's
other?
Virabegron. Yeah, there's
Okay.
Virabegron as well.
Okay. Good. Good.
Yeah.
Um, I don't find so. Just like with the situation with prostate urinary issues, where I'm saying alpha blockers are fine, right? Low, a lot of benefit, low risk.
Yep.
I've been saying the same thing with beta beta 3 agonists. Am I correct? I don't, because I don't know that group of drugs too
Yeah.
well, like I know
Yeah. So
5 alpha blockers.
so when you look at the side effects profile of beta 3 agonists, so Mirabegron was the original one that came out probably around like 2010 to 2012. And the biggest side effect with that one is it can affect blood pressure. In practice, I find that it's not a huge change in blood pressure, usually a few points. But patients who have more blood pressure issues or labile blood pressure, you want to definitely warn them about it and recheck blood pressure. Now, when you talk about Virabegron, that's a drug that's come out probably the last couple of years, and it's a little bit more specific and doesn't have the blood pressure issue, so much better tolerated. And the other thing about these medications, very low risk of constipation, no dry mouth, and
Correct.
very little to no risk of dementia. So, they've really brought up or stepped up the safety profile for overactive bladder medication.
How efficacious? I mean, clinically, you see way more of these patients than I do. So clinically, I'm like, wow, this is pretty good. And again, if it works, if we've tried the alternative, or we tried the herbs, it didn't work, or the lifestyle and either it doesn't work or it's hard to maintain, seems like a decent drug. How efficacious are these beta 3 agonists?
Yeah, I would say that like in my experience, they work fairly well. Probably like the response rate, 70% of patients tell me they have at least a 50% improvement in symptoms. And a lot of patients are pretty happy and they stay on them. But with just like every drug, I mean, anticholinergics have a tremendous fallout where 70% of patients probably don't continue the drug after about a year. These drugs seem to have a better safety profile and better efficacy profile where probably the dropout rate is probably closer to 40 to 50%. But again, it seems like from a safety profile standpoint, a lot better. Efficacy standpoint, it's, I would say in practice, I find them to be about the same as anticholinergics, sometimes a little bit not as efficacious, but depends on the patient, depends on the setting.
Mm-hmm. Mm-hmm. Before we go into alternatives and CAM and complementary medicine, we have to talk about botulinum. So, um, so I saw a systemic review from 2022. They looked at a group of men, and botulinum is Botox, and for the audience, it's the same Botox that some people use for their wrinkles. Um, A, how does it work? And B, how efficacious is it? It didn't seem to be so helpful from that perspective, from this systemic review from 2022. So, what is your experience with botulinum and overactive bladder?
Well, first, Geo, if we're going to use a generic name, it's actually onabotulinum toxin A.
That's right. That's right.
We'll
Thank
call it
you.
Botox. Yeah, we'll
We
call
call
it
it both.
Botox because yeah, yeah. But
Thank you.
yeah, so there's two things we have to look at for Botox. So there's Botox for overactive bladder, and there's Botox for enlarged prostate. So there was a multi-center, very large study done looking at Botox for enlarged prostate and injecting Botox directly into the prostate. That's where it wasn't that helpful, and it was about the same as placebo. Now, when you look at Botox for
By the way,
overactive
to me
bladder,
that
or
means to me that sorry to interrupt. To me that means so when there's a drug or a experimental tool material that's used compared to placebo, and they both come out the same. The way I look at it is, wow, the power of placebo is serious and significant. That's the way I look at it versus that the drug didn't work. But anyway, that's just an aside. Go ahead, continue. I'm sorry.
well, Gio, you do bring up a good point. Actually, when you look at a lot of the clinical studies, and I know you're very familiar with a lot of them, it's remarkable the placebo effect and about how long it could last. And sometimes you can see this placebo effect last for like up to 3 months, which tells you how multifactorial these conditions are and how
Hmm.
important it is to get rigorous testing. But you are right. When you see a drug and the placebo effect, and I will tell you, it's kind of funny because I do a fair number of clinical trials. I've had patients in the placebo arm of trials, and they'll come back to me and go, "Can I get more placebo?"
Yeah,
I'm like,
you
yeah,
know, the drug is dismissed in that scenario, and I'm saying no, no, it's not saying the drug didn't work. It's just saying that the placebo effect is powerful. So anyway, but
it
that's
is.
just so you were saying about the study in men that where they injected Botox right to the prostate.
Correct. And that's where it had very low efficacy. Now we've done a bunch of studies looking at Botox post like TERP or post laser and seeing its effect on urgency, frequency, overactive bladder symptoms. And there it has a very good effect. In addition to men who have overactive bladder and women who have overactive bladder, it's got probably like a 75 or 80% effect, where it works
That's not
really, really well.
insignificant. Yeah.
Yeah.
Okay, so maybe that's what I saw actually. Yeah, because it was only men in this trial. And so how does it work? So you're literally injecting Botox right to the bladder.
Yeah, so you're reducing bladder wrinkles. No, no, totally kidding. So what you're actually
Can you
doing
get a
is
two?
the
Can you get a two
Botox.
for one? Two for one. Like, hey, while you're there, when I'm
We,
under anesthesia, good.
yeah, so it's funny. I think a lot of patients joke about that, but unfortunately, the dosing is very different. But what you're essentially doing is the Botox actually goes and binds to the anticholinergic the synapse, and basically prevents the excretion of acetylcholine, therefore paralyzing the synapse. Over time, there'll be new receptors that get built, but essentially it takes around probably like 10 to 14 days for that receptor to get to completely like essentially non-functional, and then the effect can last anywhere between would say like 3 months to 9 months, but the average being around 6 months. So the thing about Botox is you do have to come back and get retreated about every 6 months.
It's the process. How long is the procedure? Is it painful, uncomfortable? What under anesthesia, local anesthesia? How does it work?
So it depends on the patient. I would say probably the great majority of patients that I do are done under local anesthetic right in the office. So we put numbing medicine inside the bladder, drain the bladder, inject the Botox, takes us around like probably like 3, 4 minutes, and then we're done. There's some patients who are a bit more sensitive, and then in those patients we do it under some sedation in the OR.
So for the audience, so what we're trying to do here, what Dr. Chughtai is trying to do here is so that the bladder does not contract so often, so frequently. So Bilal, the question that I have is retention. Can you overtreat? Can it cause retention because now the bladder is not contracting at all?
Absolutely. So these are the patients that I do find some form of urodynamics very helpful, whether a Eurocuff or a form of urodynamics to figure out their bladder contractility, because there is a low risk of retention that can occur with these patients. Um, so I would say that you do want to be aware of it, but the rates are fairly low. And I would say it's fairly predictable who's going to go into retention. Rates are probably around like 4 or 5% across the board.
And what are other common side effects from the treatment?
Rarely urinary tract infection. So that's the two most common side effects is urinary tract infection occurs probably less than 10% of the time. Urinary retention, which occurs probably 4 to 6% of the time.
Excellent. Any other treatments that we should talk about, or if there are too many, we can move on to alternative treatments.
Well,
Anything else?
I think we should talk about the other third line therapies, and there's two main varieties. There's peripheral tibial nerve stimulation, which is a once a week
Yeah.
therapy, small needle behind the ankle. You sit in the office for about 30 minutes, and it sends a calming electrical signal up to the bladder. Its efficacy is probably around like probably 60 to 70%. So I tell patients, be patient, but it's very low risk. So that's one therapy. The other one is sacral nerve modulation, which there's two manufacturers. There's Axonics, Medtronic's. There's rechargeable, non-rechargeable. But essentially, this goes with a lead that's implanted into the S3 foramen, and then
Mhm.
ultimately that sends a calming electrical signal to the bladder, and it's got very good efficacy as well, probably 70 to 80% as well. And ultimately, it's definitely worth the conversation with your urologist about um, the role of these medicines, role
So
of
that's
these
a
therapies for overactive bladder.
so we're gonna briefly repeat some of that because actually that's a great point. So the first one is posterior tibial nerve stimulation. Um,
Correct.
so Bilal, you'll laugh. As you know, I'm an acupuncturist as well.
Yeah.
And when that treatment came out, I sent a note to a reply to all our faculty. I said, "Hey, I could do this. This is in my mind acupuncture with electric stim, and I could do this." And it wasn't looked at favorably because so I got some pushback. I was like, okay, I'm about to get fired, and I was just new at NYU at the time. Okay, I'm gonna get fired now. Great. um, but how is it, right? Other than they've done rigorous studies on this, where in acupuncture hasn't, because they couldn't patent anything on technology or anything. How is it different? You have some idea of what acupuncture is. So there's 2 points where you can stick needles. You can definitely attach electric stim, which we've been doing for hundreds of years, or in acupuncture. How is that different?
Yeah, when it comes to percutaneous tibial nerve stimulation, in theory, it's this calming electrical signal given at a given frequency that's supposed
Hmm.
to lead to reduced urgency and reduced frequency. And Gio, you know the acupuncture sites a lot better than I do, and
Yeah.
and I agree that is one of the acupuncture sites for overactive bladder. So in some ways, there is some uh, overlap. And I think depending on the signals that you're using during acupuncture is probably
Right.
pretty similar to PTNS. In addition to that, I mean, we've actually done a systematic review on acupuncture and overactive bladder, and we found the data is actually quite compelling for overactive bladder.
Thank you. I was also involved in that paper with you, actually.
I couldn't remember Geo,
Listen,
and I didn't want to say something like Geo, the paper we wrote, and you're like, I wasn't on it. So I was like,
no,
you know
I would
what?
be like,
Let me just be
no,
cautious.
I will do exactly the opposite. That's right, Bilal. The paper we wrote. I remember. Of course, I remember. A paper just came out, another systemic review that we had nothing to do with. Literally just came out a few weeks ago, showing efficacy with acupuncture and overactive bladder as well. They're not using the same points here; it's just other points that are used in acupuncture. But another paper came out there again. So it seems to be helpful. Of course, some of our colleagues, once I posted on Twitter, I mean, they have good questions and concerns. Is like, well, how is sham acupuncture really sham acupuncture? What is sham? Is that a real placebo? And so forth. So you can. I love science and our scientific community, but one of the things we've learned from science or scientists is that uh, we could get really deep into the weeds, and at the end of the day, we're looking for clinical outcomes. How can we get clinical outcomes with some good, you know, good science? Um, the
But I think Gio, I think you're getting into a really good point, which is that every study that's done has limitations. And that's just the nature of the game. And as a result, you're right. Like in some ways, like I think the data for acupuncture looks very compelling. But one of the limitations of the data, it's hard to do a placebo acupuncture.
Yeah. Yeah. No question about that. No question about that. Um, the second treatment that I'm drawing a blank on that you mentioned after posterior tibial nerve stimulation is what was it again? I'm sorry.
Sacral nerve modulation.
That's right. That's a surgical procedure, isn't it?
It is. So it's typically a two-step procedure. We do a test phase with a temporary lead to the S3 foramen, and then you get a permanent implant that gets placed in the upper buttocks, and that implant sends a calming electrical signal to the bladder. And I also think that we should mention the fact that there's
Is it
tremendous
associated with an
innovation.
app or something? Do you control it with an app? I don't know if
There,
it's a
there
silly
is a
question, actually.
No, great question. There are controllers for both, and you would have a controller. But ultimately, once you set the signal, you don't make many changes in the setting.
I gotcha. Okay. And
But Gio, one thing,
mhm.
sorry, I didn't want, I just want to finish up one last thought, which is that, there is a lot of new innovation in the nerve modulation space. So there's new implants for where posterior to the tibia and sacral nerve implants. When it comes to therapies for overactive bladder, there's a lot of new stuff in the pipeline.
Oh, good, good. I'm going to become abreast of it. I'm sure next in May when we're at our next meeting. Um, what are the so how often do you need to go back in and either replace that that tool, or does it get infected, or what are some of the complications that may occur once
Yeah, so
it's inserted?
I would say infection rates are probably on like 1%. When it comes to revising or replacing the device, we did a study, it got published in JAMA Surgery, demonstrating that the old version of the device had retreatment rates that are pretty high, around like 20-25% in 1 year. But
Hmm.
again, those devices were not MRI compatible. The new devices are MRI compatible. So I do think that we're going to see a lot lower revision rate going forward. And that's been my clinical experience as well.
Excellent, excellent. Yep. Um, some of the staff here at NYU also do a lot of that, but I just never dug deep into it at all. Is it mostly do they do this type of therapy mostly to women versus men, and if so, why?
Again, it's more prevalent in women. So we see it more commonly in women. But I would say that in my practice, there's a fair number of men who we do this therapy for because we see a lot more, we're diagnosing a lot more overactive bladder in men.
And as we spoke about earlier, I think the real numbers are probably 50-50 men women if we blame the organ we have.
Yeah.
we blame the we blame the organ we
Yeah.
have.
It's like when in
Altern-
doubt, blame the prostate.
exactly. Urinary prostate. You have one, right? Oh, you don't have one, so
Well, now it's a bladder. If you don't have one, it's a bladder.
exactly.
Yeah.
Alternative therapies. Now, I could talk a lot, but I'm always interested in your perspective, right? Because it's not like you're trained. Like I was trained in natural medicine, right? And then I went into urology. You did the reverse. You were trained in urology, and then you had some interest in alternative therapies. Personal question first: Did it? I know we spoke a little bit about it earlier. I'm always interested because I believe you come from Indian descent, and so I often find that those that come from Indian descent have curiosity about herbs and herbal therapies and things because their grandma or Ayurveda or things like that. Is there a connection there with you at all, or not that much?
Yes, so my family's Pakistani, but
Pakistani.
for me, yeah, so for me, the interest
Same
really came from the
same in
fact
terms
that
of history and use of herbal
very,
medicines.
very
Yeah.
similar. But it wasn't really more familial, but it was more like I started practice and I would see patients come in with bags full of supplements. And, you know, being trained in obviously in like, Western medicine, I was kind of like, you know what? These don't do anything. Like, how dare you? Like, why are you using these? And then,
Right.
then I also thought this is getting irresponsible of me. I feel like I should know more about this. And I should also know, like, I should be able to guide you a bit. Like, where's data? Where's there no data? Where is there animal data? Where is there some data to support its use or not its use? So I started changing my language a bit, saying that, look, um, we have supplements, right? And no one regulates it. It's the Wild West when it comes to regulation. But that doesn't mean that some of these supplements don't work. And there have been companies along the way that have also been very interested and very vested in science to back what they do. And I think that's what really got me interested because then we had clinical data to support the use of some of these supplements for a variety of conditions.
Hmm. What are your top five for OAB in terms of anything? I would say mostly herbal, but in terms of any complementary alternative treatment that you would say, yeah, when my patient says I'm taking X, I say, sure, keep taking it, or you recommend it yourself.
Yeah, so the one that we've actually done a clinical study with, we've actually done one with a freeze-dried cranberry, and we actually had very good outcomes. It was a study of I want to say 77 women that were randomized to placebo versus this cranberry supplement, and they actually had a pretty remarkable improvement in their urgency and frequency episodes. Granted, we only focused on patients who did not have incontinence, but I was really surprised by how well they did. So that's a supplement that I typically would recommend because we've got some scientific backing behind it. I do tell them limitations, like it wasn't a multi-center trial, it was only 77 women. When it comes to other
Did
overactive
they
bladder
have no
therapy,
urinary tract infections? Because I find
it
that
is
to be
not.
interesting. So, typically, historically, cranberry products have been used in people who have a history of urinary tract infections because there seems to be benefits there in terms of the bacteria attaching to components of the cranberry so that you can get it out of your system. What's the mechanism of action for cranberry for this particular type of cranberry product in overactive
That
bladder?
That is a excellent question. So one of the things in the study we did try, we didn't have a clear-cut mechanism of action, and that's actually further studies that we're trying to, trying to get funding for and trying to do because we want to try to figure out if there is, what could be playing a role. Does it have to do with something like microbiome? Does it have something to do with affecting the urothelium itself, the GAG layer? So don't know at the moment.
Great. Um, Complementary medicine number two. What would that be?
Yeah, so I've seen like there are times where patients will come in with sometimes like pumpkin seed extract. So I will tell them like there is some limited data on it. There are some extracts that I can't pronounce very well, like Ginkgo biloba. I think you should correct me on that one. So that one's got some data to support its use as well. So those are the three that I'll point patients towards and say that, look, if you're going to try something, these are the three that I have you think about. But I also warn them that I don't have, um, there's not a very good, reliable manufacturer that I would say, hey, this is the manufacturer
That's right.
to go for. I think for cranberry, we now have, I think we have some that seem very promising, but we also need obviously more clinical data to support its use.
By the way, I also don't. That's a Japanese herb that I ginkgo biloba, and I also don't pronounce it overly well either. So,
Thank
but yeah,
God, at least I'm not the only one.
no, yeah, exactly. I've struggled a little bit with that one as well. I think I struggle with a lot of some of these pronunciations. We had to learn the Latin and herbal medicine, and it was like, oh man. Um, any other in general, any other therapy? It could be herbal. Doesn't have to be herbal. Any other practice, yoga, anything that you can say, yeah, this there's an association here, correlation. Even if it's correlation, that's positive.
Yeah, so Gio, I think you're going to get into like the other stuff that we're really talking about is that we know there's multiple factors affecting overactive bladder. Um, and sorry, the lights go out in my office at 7 o'clock. They'll turn
This
back
is
on in
a
just a
real
minute.
cool look. I would have asked you to have this done, to have this look. So there's people listening on the podcast. Eventually, this come out on YouTube. So Dr. Shuktai's office just went dark, and he there was almost like a red light on him, and that just it was a sudden change. It was cool.
Um, Yeah, but again, it gets back to how these conditions can be multifactorial. There could be pelvic floor dysfunction. There could be obviously nerve issues, muscle issues. So the role of pelvic floor exercise, the role of yoga, the role of stretching, there's lots of things that can have net benefits in reducing urgency, frequency, and the symptoms that go with it.
Our friend Amy Stein, she's a physical therapist and she's a pelvic floor physical expert and therapist. And so her practice specializes in that. Anything that she can do that you know of, not details, but in terms of, in other words, a patient with overactive bladder, but man, there's no evidence that you can tell there's pelvic dysfunction. It's just
I
overactive
would
bladder.
tell
Is
you
there
that
benefit?
I think there is. I mean, I've had lots of patients that have gone and seen her and her group, and they've had, very good improvement. What I tell patients is that, in some places we don't have tremendous data. And I think when it comes to plain, like overactive bladder, right, there's definitely data to support the use of pelvic floor physical therapy. I think that it is helpful. I think those with underlying pelvic floor dysfunction have tremendous benefit. But it's hard to say what came first, right? Did you get overactive bladder? Did your muscles become tight because you've had to hold it for so long? So I think there's definitely a net benefit for that therapy.
So my last question is the following. So we know there's likely a 50-50 chance male female that is overactive bladder
Mhm.
for females and males. Is there any difference between the way you treat a all things being equal, the way you treat men versus women with overactive bladder, or you would recommend similar things to each gender depending on what?
Yeah, so it is. So first line therapy is the same. You're still going to recommend, reducing waist circumference, pelvic floor exercises, the use of reducing bladder irritant. So that's going to be the same. In men, you want to have that discussion between, is it possibly enlarged prostate versus overactive bladder? And with some men, if we have if I have a good historian and we talk about the role of weak flow, whatever it might be, I mean, we'll go and follow a very similar pathway. Usually when it comes to invasive therapies, I typically do urodynamics prior to any invasive therapy. So it's a pretty similar pathway for both genders.
Great. Bilal, any last thoughts? Overactive bladder, guys, what's the most, so I try to teach patients to when they're seeing a urologist that, look, let me make it ask good questions so that it's most efficient and you get the answers you're looking for, and respect their time, they respect yours, and da da da. Anything that you would suggest to patients to say, hey, when you see a urologist for overactive bladder, for anything, these are the things, like, just be what? Is there anything
Yeah, yeah. So
that
Gio,
makes it
I
easier in
think
your
the one
practice?
thing, yeah. So I think Yeah. So one thing I would actually go back about is that what's really hard about overactive bladder is that some of the conditions that we treat don't have a lot of associated conditions that go with it. But we know that overactive bladder is associated with depression, anxiety, social isolation, and there have been studies that actually show that some people rate that state of urge urinary incontinence as a state worse than death. So the
Mm,
point is, in a lot of ways, you got to tell your doctor. You got to tell somebody. Like, start the conversation because there are a
interesting.
lot of good
Mm.
therapies out there, and in a lot of ways, like just by starting that conversation, hopefully we can reduce the impact on quality of life. And because ultimately what ends up happening is that, remember, overactive bladder is unpredictable, right? So what do you start doing? You want to bring predictability back. So what do? You stay home. You go, I'm not going to go to the gym. I'm not going to go for a walk. I'm not going to go outside, right? So you start reducing activity. What does that do? Exacerbate the condition. So in a lot of ways, like, there's a lot of silent sufferers with this condition. And I think it's important that we bring that up to the listeners, that if you have this condition or know someone with this condition, bring it up to your primary care doctor. Start the conversation.
That's a great point. Look at it holistically, which I think is, all the systems are interrelated. Any idea what comes first? Depression or overactive bladder first, and then any idea?
And it's like the chicken and the egg argument. Hard to
Yeah,
say,
yeah,
but
yeah.
but but we know that they're very highly correlated, and addressing one definitely helps the other as well. But it's important to know that they're very highly correlated.
Man, wonderful. Listen, any final thoughts? We're coming close to the end. This has been great. I think this is a wonderful. I wouldn't call it a master class because a master class would be more like 8 hours, but for 1 hour almost, this was very good. Any final thoughts, Bilal?
No, no, this is a great conversation. Really enjoyed this, and thank you for having me, Gio.
Thank you. Where can people find you
Uh, in terms of for my
online?
practice is on yeah online. Though you can check out my profiles on the Weill Cornell website, and
Hmm.
I practice on the Upper East Side.
Upper East Side, New York City. Hey, Bilal, thanks so much, and thanks for your time. Have a great evening, and I'll see you soon. Thanks so much,
You too.
brother.
Thank you.
Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.